Okay. All right. Last but not least, we have a special treat this evening for those of us who soldiered on until the end. Paul Pockros is joining us from all the way from sunnier for sure, San Diego, to give us his perspective on hepatitis C, the journey from discovery to cure and elimination. It's difficult to introduce Paul, to be honest. Paul is a person who has really been at the forefront of hepatitis C from diagnosis to cure, and who's been a very pivotal contributor through clinical trials and other things to this journey that we're hopefully going to see to fruition with elimination of hepatitis C. Paul went to USC for medical school and residency, did his fellowship, among other places, at Rancho Los Amigos. So I guess technically, Paul, you're from the Telfer Reynolds tree, right? Isn't that what you consider that?
Correct.
Yourself that? Yeah. I mean, Marty, didn't you go to? Marty is from the Telfer Reynolds tree too. So a very illustrious place to train in hepatology. Paul has been at Scripps for a long time as division chief and other responsibilities, leads a research consortium, and has very much focused on hepatitis C throughout his career. And I think that's about as fair an introduction to Paul I can give. We are honored and privileged to have you talk to us about hepatitis C, the journey from discovery to cure and elimination. Thank you, Paul.
Thank you for the introduction, Pierre, and I'd like to thank the organizers and apologize for not being there in person. I was planning to be there in person until I came back from Boston and got COVID and had to scratch a whole week of work last week, and there was no place to move the patient, so I had to stay home this week. However, I'd like to just summarize, kind of take you through the story. First of all, these are my financial disclosures. The story will not be complete for hepatitis C unless you first talk about the 2020 Nobel Prize in Medicine that was awarded to Harvey Alter, Michael Houghton, and Charles Rice, because they really are the key guys that came up with this disease. So you have to frame where we were in the 1970s to really understand the importance of their discovery. I've attended the HepDART meeting with Harvey Alter and Charles Rice for 30 years, and I've known them quite well, and I can tell you they're not a whole lot different than us, except that they work very hard, and they're razor focused on one thing. So in Harvey Alter's case, he was razor focused on clearing the blood product pool in the United States, which was, they knew in the 1970s, caused viral hepatitis in a fair number of recipients. They had a hepatitis B test, so they were able to screen blood for hepatitis B by the mid-1970s quite well. And they had a fairly good hepatitis A test, and hepatitis A was not causing post-transfusion hepatitis. So, and now that we know more about the life cycle of hepatitis A, we know that's because the viremia stage is very brief, maybe an hour or two, and then it's shed in the stool for the next year. So, but they still found about 8% of recipients of blood products developed this non-A, non-B hepatitis, and they wanted to get rid of that. So what Harvey did was collect pedigreed serum from over 100 patients where this had occurred, and they then injected the serum from these patients into chimpanzees, and they developed a viral hepatitis-like illness. So they knew they were on to something. Then Michael Houghton took chimpanzees that were infected and made a phage library of over 1 million different sequences, small sequences, and tested them against serum from these patients that had pedigreed patients with non-A, non-B hepatitis. And when they came up with a positive match, they sequenced a small genome, 100 nucleotides long, very small. This was the ELISA-1 test for hepatitis C. And then it led to the ELISA-2 test by 1991. And we were off to the races with a good test for hepatitis C. Then we were able to sequence the whole viral genome, and Charlie Rice showed that if you took the transcripts from these sequences and inject them into a chimpanzee, they would then develop this non-A, non-B hepatitis, demonstrating that this was definitely the cause of hepatitis C. So they came up with the structure of the single-stranded RNA, the E1 and E2 glycoproteins, the capsid, the envelope, and that led really to our discovery of the virus. And this was when I was trained at USC Liver Unit. My interest was in ascites. And this kind of came about after I was already a hepatologist at Scripps, and it was very exciting to see it develop. And there weren't very many people interested in it. There were only 18 centers in the United States that cared about hepatitis C. So we got together and did a lot of the hepatitis C studies. We were fortunate to do that. So I'm going to take you through briefly where we are now with screening, changing demographics. They've changed a lot since our first studies in the 1990s, and then go through linkage of care, treatment, where we are now, follow-up of after cure, and elimination, where we are with DAA. So testing now is quite simple. We test all patients over age 18 one time, that's recommended. And patients that are in prenatal phase should be tested during pregnancy, and that's done routinely in pregnant females. And patients that use drugs, PWIDs, or patients that have unprotected sex with men or on PrEP, they should be tested more than once. So annually, they should be repeat tested. Same with patients in dialysis centers. So the CDC has been pushing this for many, many years. We've all seen these posters and billboards and TV advertisements, et cetera, that everybody should be screening, but it's still, we've not done a very good job in the United States in really doing this. In our center, we've added opt-out screening to the laboratory tests in EPIC system, and many people have done the same. Many centers with electronic medical records have done the same. But the population that we started with in the 1990s, the baby boomers born between 45 and 65, they really have faded away. So it's rare that we ever see a patient in that age group diagnosed with hepatitis C now. Most of them have been either treated or transplanted and treated, or died. And I unfortunately have seen hundreds and hundreds of patients over the decades die from complications of liver disease, cirrhosis, liver cancer, and other complications related to hep C. So the generation now is the millennial population born between 81 and 96. And unfortunately, there's a very large number of them that are hepatitis C infected due to the opioid epidemic in the United States, which we see plenty of in California, and I know you see plenty of in Ohio. So the recommendations, again, in patients that inject drugs is to identify them, screen them, and treat them, regardless of the setting. So the real reason for this push is that if you treat infected patients that are using injected drugs, you will diminish transmission greatly. In fact, John Ward from the CDC says you only have to cure about 15% of those PWIDs in order to eradicate transmission of the virus. So you don't have to cure them all. So there's a big push to do that. Now, the other issue we're running into with screening is that it's not just the patients in the NHANES population that have hep C. There's also lots of patients that are homeless, incarcerated patients, and other populations that are not included in the NHANES population. So if you look at just NHANES, the overall prevalence is less than 1%. But if you include those other populations, homeless and incarcerated, it's close to 11%. So you end up with a lot of patients that have hepatitis C that have not been identified. Black Americans bear a disproportionate burden of homelessness, and therefore Black Americans are disappropriately infected with hepatitis C. If you look in African American males in their 50s, 1 in 7 is infected with hep C. There's also a problem with progression of disease, that Hispanics tend to progress more rapidly, likely because of comorbid factors of obesity, diabetes, all the other factors that are causing NASH. But Hispanics tend to get more severe liver disease. We have a large Hispanic population in Southern California with hep C, and they are estimated to be 60% more likely to die from hep C if they're infected than non-Hispanics. So there are a lot of reasons that we can't treat these patients right now, but we're trying to overcome these barriers. And we in our own center are working on doing this, referring to mental health, addiction medicine. Physicians are on the front line seeing most of the patients now that are in the opioid epidemic. So therefore, they're seeing the patients that are infected. Harm reduction with syringe exchanges, which is allowed in California. I'm not sure it is in Ohio. But there are a number of other tasks that need to be done, and collaborate with specialists, especially in rural areas. And, in most centers, we have additional providers such as extenders, mid-levels, et cetera, that are seeing a lot of the hepatitis C patients in the large GI groups, and they're doing a lot of the diagnosis and treatment of this population. There are also some simple steps, such as using low dead space syringes. This is very easy to do. A low dead space syringe reduces the transmission rate by 75%. But in order to get a low dead space syringe into the IV drug using population, you have to have a syringe exchange set up in order to do this. So, and it's only going to be possible where you have formal syringe exchanges. So, summary of diagnosis, just remember exposure usually does not produce symptoms. 80% of patients are asymptomatic, so most patients infected don't know it. Everybody over age 18 should be tested. Once pregnant women should be tested during pregnancy. Patients who are PWIDs or MSM should be retested on a regular basis. If you get a positive HCV antibody, you now do a reflex HCV RNA test. Those that are identified as being infected should be counseled not to drink, and should be tested for hepatitis B as well, and referred for linkage of care to somebody that's going to treat them. So let's talk about treatment. Now, in our era, treatment was more complicated because most patients had previously been treated with interferon. Many patients in our practice had cirrhosis by the time we had direct-acting antivirals available. Some were not decompensated, but some were already on the list. Many were older, so they had end-stage renal disease, a lot of HIV, hepatitis B infected patients, and a number already had developed liver cancer or had a prior liver transplantation. These patients are not eligible for simple treatment, but most of the patients that are being identified and diagnosed now are eligible because they're young, they don't have any of these other factors, they don't have prior therapy, they don't have cirrhosis. Most of them have genotype 3 and acquired their infection through IV drug use. So in that case, it's very simple. You screen them for blood count, hepatic panel, renal function. You do a one-time HCV RNA to confirm that they're really positive. You do an HIV test and a hepatitis B surface antigen test, and you make sure they're not pregnant if they're females. And then you can go ahead and treat them. Remember, viral load is not predictive of disease progression, so the level of viral load that we measure really only verifies that the patient's infected. And if we see a low viral load, it's often because the patient's had an acute illness and they're often clearing their infection when you caught them. But we still would treat those patients now because of their risk of transmission. There is a risk of maternal fetal transmission that's related to viral load. We don't have to check viral load while patients are on therapy any longer because it doesn't predict resistance. We no longer believe that prolonged therapy with detectable virus leads to resistance. So what do we have to do? We have to assess a patient for fibrosis because those that have advanced fibrosis or cirrhosis are going to be followed indefinitely after you've cured them. And those that are not, that have mild or no fibrosis, you don't have to follow. So you can do this simply with a FIB-4 or one of the other cirrhosis assessments that you already heard Dr. Alkiri talk about this evening. So we use the same thing, transient elastography. We have 5 of these at Scripps. I have 1 in each exam room, and I use them all day long, as do our PAs and other transplant physicians. You can use non-invasive serologic tests that are proprietary. You can use evidence for cirrhosis just based on scan or low platelet count or prior liver biopsy. We used to do liver biopsy on everybody with Hep C, and we used to do repeated liver biopsies in the 90s. And it's rare that we do a liver biopsy now on a patient with Hep C. You really don't need to do this to assess fibrosis. You need to know what medicines are on in order to assess for drug-drug interaction, and you need to educate the patient to tell them that they need to come back at the end of therapy and at least a month or 2-3 months afterwards to confirm that they're cured. So the FIB-4 calculator you heard about already, it's built into our electronic medical record, and it's a combination of age, AST, platelet count, and ALT, square root of ALT, and it's simple to calculate. FibroScan, I mentioned already, we use routinely. MRE, we don't use as much in our center, except for patients that are morbidly obese and we can't get a reliable elastography, or patients that are in NASH trials, we may use MRE, but we have the technology, but of course it costs more, and you have to screen, go through radiology to get it scheduled, whereas a FibroScan you can do at the bedside. As I mentioned, there are commercial tests that are proprietary. You have to pay for these, but there are a lot of tests you can do that are just simply bedside tests. So cirrhosis assessment, pretty simple, no liver biopsies required. You do need to know if a patient has advanced fibrosis. On elastography, we consider 12.5 kilopascals is high enough that you have to follow that patient indefinitely, or a FIB-4 score above 3.25. Or you can simply use platelet count. I mean, that's what's done. That's what we used to do. Anybody with platelet count less than 150,000, you assume has cirrhosis, and you just treat them as such. And their outcome is very different. If this is decompensation, looking at the difference in decompensation, this is from the HALT-C trial database. And you can see patients with a platelet count under 150,000 have a much higher rate of decompensation. The same thing is true with HCC, et cetera. So the goals of therapy, just to review quickly and remind you, the goals of therapy with Hep C are different than hepatitis B or HIV. And the primary reason for this is there's no archived form of DNA in the nucleus with hepatitis C. So in hepatitis B, you have covalently closed circular DNA, and in vertically transmitted patients, you have probably most of them have the genome is already integrated into the host DNA. So you treat the patients and you can clear the virus from the cytoplasm and from the serum, but you can't clear it from the nucleus. with the antiviral therapy we use. So if you stop antiviral therapy, you're usually going to have that patient relapse with replication from one of these two sites in the nucleus. Same with HIV, where the cell, of course, is not a hepatocyte, it's a T lymphocyte, and the proviral DNA gets integrated into the genome of the T lymphocyte, and you have to keep antiviral therapy going. That is not true with hepatitis C, and we knew that 30 years ago. John McCutcheon and I did a study at Scripps where we simply sent the phlebotomist to the transplant operating room when a patient was having liver transplant and measured viral load every 5 minutes, and found that the viral load dropped from a titer, the typical titer of 10 to the 6, down to undetectable in about 30 minutes. And it stayed that way in many patients for up to a month before it came back up. And we were able to give that data to a smart mathematician who figured out the half-life of the virus, figured out there's 10 to the 13th replications of virus per day, etc. But the important part is that the virus does not enter the nucleus, and so if you can interfere with viral replication, you can do the same thing. The lifetime of the virus is about an hour or two, and that's it. So if you can block its replication at more than one site, you can cure the disease, and that's what we've been able to do. Now, we've known already for a decade that, this results in reduced mortality and reduced liver transplantation. And this study published in JAMA showed that those without an SVR did not achieve this endpoint the way the patients did with an SVR. And of course, this data was all based on interferon therapy because it was published in 2012 before we had DAAs. But it was also true of liver failure, hepatocellular carcinoma, but interestingly, it was also true of all-cause mortality, which is why we treat everybody, even those patients that we don't think are going to die from liver disease. I've seen some patients show up in their late 60s or 70s, usually females that are thin, that never drank, and they don't have serious liver disease. And they acquired their Hep C 40 years ago, but I tell them they should be treated anyway because it reduces their risk of stroke, cerebral vascular disease, extrahepatic malignancies. We don't know why exactly, but it does reduce all-cause mortality. So therapy of hepatitis C has evolved over 25 years, really from the first study we did with interferon in 1990. We had a cure rate, which was defined as a normal ALT for 6 months after therapy, of 2%. And we thought that was actually pretty good. But we went from there all the way to SVR rates greater than 98% by 2016, of course, with the advent of the combination DAA therapy. So really the key landmarks of drug development were 1980, when Dan Bradley figured out that that non-A, non-B hepatitis could be given to chimpanzees. Then Michael Houghton, I told you about already, in 89, came up with the first ELISA-1 test. Then Charlie Rice figured out the replicon, where he did his work, and then they were able to culture HCV in cell culture. In 2009, this published an important publication in Nature on IL-28B, showed that there was genetic variation and that African Americans did not respond as well to interferon. And then Mike Sophia in 2013 made the very first effective NS5B polymerase inhibitor, which he named sofosbuvir after Sophia, of course. And that came after our first protease inhibitors, boceprevir, telaprevir. So once we could combine drugs, we were off to the races. By 2012, we had the Cosmos trial combining cimipravir and sofosbuvir. and we were already seeing cures in our pre-transplant patients. Then that led to the combination with ledipasvir, sofosbuvir, which is Harvoni, and these other combinations outside the U.S., used largely outside the U.S. And then the next generation, which was pan-genotypic, of Sofvel or Epclusa and GP, which was Mavorite, and these other drugs. This was not used for that long, Vicarapac, and these other drugs, this one from Merck, and Sofvel-Vox was approved for patients that were non-responders. So that's really summarizing 25 years of drug development. But the antivirals we have now are the protease inhibitors, the NS5A inhibitors, and polymerase inhibitors. Protease inhibitors end in Previr, the NS5A inhibitors end in Asvir, such as ledipasvir, and the HCV polymerase inhibitors end in Buvir, such as sofosbuvir or sapropivir. And of course, we combine these together so you have multiple targets being inhibited at the same time. So valpatisvir, sofosbuvir is this combination. GP is this combination of a very potent protease inhibitor and an NS5A inhibitor. And the others, we don't use sapropivir, elbasvir any longer, but it's still approved. So the principles of DAA therapy: no interferon. You're combining drugs at different targets, and these typically have a backbone drug that's very potent. And this has led to near universal efficacy in all genotypes, short duration of therapy, and the side effects are really minimal. So the combination regimens that are still on the guidelines include ledipasvir, which is Harvoni, and this is a 8 to 12 week regimen, works for most genotypes, but Sofvel works for all genotypes and it's 12 weeks. GP works for all genotypes and is 8 weeks in most patients, and the cure rates are close to 100%. So we can now also check HCV RNA 4 weeks after therapy, and we do this routinely now rather than waiting 12 weeks. This was data published by Julio Gutierrez a couple of years ago, showing that the 4-week SVR data is just as good. And if you got a breakthrough or a late relapse, then that tells you your patients got to be retreated or you have to do something else with them. But most of these patients are cured and achieve a sustained virologic response, which is a cure. So if they did not have advanced fibrosis beforehand, you're pretty much done with that patient. You send them back to the primary physician. So it's simple steps. You don't need to be a rocket scientist or a hepatologist to do this anymore. It's, you do some blood tests. At baseline, you give your combination. This happens to be Mavorite. Here it's 3 pills, 8 weeks. Follow for either 4 or 8 weeks, 4 or 12 weeks, excuse me, do your RNA, confirm that it's undetectable, and then you're cured. If they have more advanced disease, you have to keep screening them for liver cancer after that. And with Epclusa, the same thing, except it's 12 weeks of therapy and 12 weeks of follow-up. Same thing applies to patients with cirrhosis. There are therapies we have now for patients that have failed, that very small number of patients that fail therapy. So they can get combination of Sofvel-Vox or a longer duration, 16 weeks of GP with sofosbuvir. And there are treatments we use for decompensated patients. For a decompensated patient or a patient with clinically significant portal hypertension, keep in mind you should not be using a protease inhibitor. They are contraindicated in that setting. Also keep in mind you should test for hepatitis B in patients because they can reactivate if they've got hepatitis B. This was a bigger issue during the baby boom population where 50% of them were simultaneously infected with Hep B. Most cleared it, so they have core antibody, but some of them actually had hepatitis B still, and they could relapse and reactivate if they were treated. We use the Liverpool app on our cell phones to look for drug-drug interactions, and that can, of course, because a lot of the older population is already on a lot of meds, statins, etc., PPIs, and that will help define which regimen you use. For younger people, this probably does not apply as much. So in summary, we have a simplified guidance for therapy. We really only use 2 regimens in the United States, which are GP or soft fill. Monitoring is really not required. A viral load during therapy, you do need to check after therapy, either at 4 or 12 weeks, to confirm the patient's been cured. And you don't have to do any liver follow-up after that if they did not have advanced disease. So let's talk about that briefly. What about patients with advanced stage 3 to 4? We thought they were going to reverse their disease and you could stop treating them or stop monitoring them for liver cancer. That's what we anticipated. We thought was going to happen 10 years ago. It really has not happened, unfortunately. So first of all, many patients have gone on to either become obese or diabetic or alcoholics, even after they're cured, and those patients can get more advanced liver disease and then they're at risk. Second of all, we showed in a study that was done by Jason Pan, who's now at WashU, he's a hepatologist there, he showed that the collagen content after cure is reduced by about 50%, but these patients still have structural cirrhosis or stage 3 fibrosis, so they're still at risk for liver cancer. So the rate of liver cancer with an SVR following DAAs goes down, definitely, but it does not go to 0. So we can't stop screening these patients, and I'm sure you guys have seen patients 10 years after cure like we have. We've seen, we just saw a patient show up 13 years after cure with an HCC out of nowhere. So it's very disconcerting, and we have not stopped screening these patients with more advanced fibrosis. So it's very clear there are benefits from cure. The all-cause mortality has gone down. The liver-related mortality has gone down. And if you're in a transplant center, you know what's happened with Hep C. Basically, we never see a patient transplanted any longer for just Hep C. You do still see some hepatocellular carcinoma cases, but not just Hep C. It's gone. So that started around 2012 when we had the Sim-Soft combination, and it's disappeared now, as Dr. Alciuri showed you. Now NASH has largely replaced this, and alcohol is still the major indication for liver transplant in the United States, but in females, it's NASH and second leading cause overall. So the benefits of direct-acting antivirals, if you look at the Cochrane analysis that was published now in 2018, it's old, and it says there's no proven benefits of direct-acting antivirals. The next Cochrane analysis that's published will not say that. It will say there are benefits. Clearly, it reverses cirrhosis, reverses portal hypertension, cryoglobulinemia has disappeared, liver-related mortality, all-cause mortality, transplant delistings, all these things I've shown you have clearly shown the benefits. We see less of these extrahepatic manifestations as well. HCC, the verdict is still out, especially if they had advanced fibrosis beforehand, so we have to keep screening for that. And fibrosis regression is not, it is reversing, but it's taking a long time, and it's not getting rid of the risk for HCC as quickly as we had hoped. Now, lastly, let's talk about elimination. There's still 71 million people in the United States infected with Hep C. Some of these are in the United States, but many are in other parts of the world. Egypt had the highest prevalence of Hep C, and they've almost eradicated Hep C in Egypt, but many parts of South America, Africa, Russia, etc. So what do you do to get rid of Hep C in the rest of the world? Well, the HIV approach is one rational approach, which is you give branded distribution of your drugs either for free or a very, very low price, or you allow generic licensing of your drugs all over the world, which Gilead has done for their backbone drug Truvada or tenofovir for HIV, and that allows you to treat hundreds of millions of people in the world and millions of people in low resource countries for a very small cost. So if you look at the cost of tenofovir, it's gone down to $4. So you can treat almost 97% of HIV therapies in developing countries are now generic versions. So you could do the same thing with Hep C. What's the situation in the United States? The CDC gets a paltry sum, $40 million for viral hepatitis funding. That's not enough. The White House last year announced that they are going to have a big push and try to eliminate Hep C in the United States by 2030. That's the goal. So the Biden administration has promised $2.5 billion distributed over 6 years. So the goal is 90% diagnosed, 80% treated, 65% reduction in mortality, 90% reduction in HCV incidence. You're talking about, we still have about 3 million people. So we're not anywhere near on track to do this right now. We're on track to accomplish this by 2051, not 2030. And most of the world is also not on track to accomplish this. So how are we going to do it? Well, Egypt has really done this. This is published in the New York Times a couple days ago. Egypt has pretty much eradicated all the Hep C in that country, and they will be on target to meet that goal by 2030. And they're now trying to teach this to the countries in Africa where they have a very high prevalence of Hep C. So it's a lot of it is not technology, it's just work. It's a lot of effort. And the AASLD has outlined this. This was published by Nora Terrell in Hepatology this year, talking about what would be necessary to eliminate Hep C with diagnostics, research, advocacy, patient care, capacity building, patient education, et cetera. Even vaccine is still being worked on. We do not have a hepatitis C vaccine, as you know. So there's a bill that's going through Congress right now that's likely going to achieve this. And I think if it gets passed, then that funding will go through and maybe we'll be on track to get rid of Hep C by 2030. If you're really interested in the journey from discovery to cure, this 2-volume text was published by Michael Sophia in Topics of Medicinal Chemistry. It's about 2,000 pages long, really dry reading, about as dry as possible, but it tells the story in great detail as to how this actually was all accomplished. Thank you very much.
Thank you. Thank you very much, Paul. That was fantastic. We were not planning to take any questions for our keynote speaker, but does anyone have any? It's 8:34 here. So anyone have any burning questions that they would like to ask Dr. Pockros? Okay, well, if not, thanks so much, Paul. We appreciate it. And I don't know if you're going to Cabo tomorrow, but if you are, I'll see you there.
I'll see you on Monday.
All right, there you go. Bye.
Thanks, guys.
All right, I think we're done. Thanks to everyone who stuck it out till the end, till the very bitter end. This was wonderful. If you have not had enough hepatology today, then you'll never have enough hepatology. Hope to see you next year. Yeah. Yeah.